Well, friends, my topic is more of a clinical oriented and easy sounding, but not so easy to manage. That is the management of abdominal distension in the patients admitted in a critical care state in an intensive care unit. I'll start with a practical clinical problem. Say 79 years old hypertensive coronary artery disease Parkinsonian patient gets admitted for obstipation, abdominal pain and distension for more than 3 days. Patient doesn't have much pain, occasional vomiting, no fever, chills, no bleeding. Vitals are stable, but abdomen is distended, soft, bowel sounds are sluggish. No masses, just vague tenderness at left upper quadrant. Labs are more or less normal except for mild hypokalemia. There's no leukocytosis, mild leukocytosis. Well, if a patient walks into the ICU, what is the various possibilities? If you look at the background of the patient is coronary artery patient has got Parkinsonian disease, is on multiple medicines. The various things which come to our mind, abdominal pain is not the dominant symptom. The various things which come to our mind will be, is it some sort of a mechanical obstruction of whatever etiology? And when we talk about this mechanical obstruction, please in this setting do not forget a fecal infection. Is it some sort of a toxic megacolon, which is now seen more often in the patients who are critically ill or who are otherwise chronically ill due to Clostridium difficile toxin? And should we check for that? I think this is one issue that we should, if you're suspecting that, today's time we must check for the Clostridium difficile. Is it some sort of a ischemic colitis? The patient is prone to it. Patient is an old age coronary artery disease patient and can have a ischemic phenomena and can have more or less the same presentation. And of course, intestinal perforation. But in addition to all this, what is the relevant topic for today is what we call as acute colonic pseudo-obstruction, and that's what I'm trying to focus on today. But when the patient walks to us, I think the first and foremost primary thing is to get a plain X-ray done. And this is the usual picture in this patient that we saw of a hugely dilated ascending and transverse colon. There are few things which we need to look at. If you look at the differential diagnosis, make sure that there is no free air, so you rule out that there is no perforation, and that's it becomes difficult to get an erect film in the patient. So before you move on to the ICU, please get a sitting position X-ray, or at least make sure that you are not missing anything, or percuss the hepatic area. If we find the obliteration of the hepatic dullness, then one starts suspecting, and then one likes to go for a CT if you're not sure on the plain X-ray. Rule out mechanical obstruction. It will be, see the small bowel obstruction. If you look at it, the bowel loops here are predominantly large bowel. The small bowel loops are not being seen. But here, the most important carry home message is, don't forget to put in a finger in the rectum and miss a fecolates there or a growth there, because then simple things will be missing, and simple methods. So that's the second lesson, that after plain X-ray, don't miss the air under the diaphragm. Don't forget to do a rectal examination and made gross mistake. And the key thing here is to diagnose acute colonic pseudo-obstruction, that you can see air till the rectum, till the lower end. So once we see that and the bowel sounds are sluggish, there is no air in the diaphragm, then the diagnosis is more or less confirmed of acute colonic pseudo-obstruction. And of course, to differentiate between a colonic volvulus, which is a U-shaped colon. I just want to show that. And one is doubt, one goes for a CT scan and sees the dilated thing. So this acute colonic pseudo-obstruction was first described in 1948, is also known by the person who described as the Ogilvy. And it basically means marked dilatation of the colon in the absence of mechanical obstruction. And usually develops in hospitalized patients over a period of days, but 90% of the affected patients will have an associated medical or surgical disease. And there's a long list of diseases: cardiac, metabolic like alcohol electrolyte imbalance, neoplasia, post-traumatic, a lot of drugs, especially the antidepressants, anti-Parkinsonians, opiates, patients of malignancies on painkillers, quite often will get into that, or acute cholecystitis, pancreatitis, and this is another group of patients, that is the neurological patients, so spinal cord disease, Parkinsonian, which our patient had, and the post-surgical, especially the spinal cord traumas and hip surgery, kidney transplant, or even post-cesarean sections. So there's a huge list of conditions where this situation we can face this situation. And the diameter of the colon is usually almost up to 9 centimeter, and extremely rare that as a perforation can occur as a complication of this condition, but it's not very common. It's rare in about 3%, but once it occurs, it is more or less catastrophic. Whenever in doubt, please don't hesitate to go for a CT scan or a soluble contrast barium anemia, and if in doubt. But most of the time, the diagnosis is clear by the clinical examination and the simple plain X-rays. And if still in doubt, then do a colonic with an unprepared colon. Do a colonic as a diagnostic. I'm not talking about decompression, that I'll talk later on. I'm just talking about the diagnostic part. Now, once this patient is there, then how do we manage that? I think the first issue is rule out mechanical obstruction and make sure the diagnosis is clear. And then it's the general conservative measures are used, which is basically nil by mouth, nasogastric tube. May not be of much help because it's mainly a colonic obstruction, but it definitely decreases the vomiting and other symptoms in that. And of course, in some patients you may use a flatus tube and take care of the potassium or calcium, magnesium, frequent change of the posture, and if most important thing is to look after the underlying causes like sepsis, hypoxia, hypovolemia, and serially follow the colonic diameter by the abdominal X-ray, and of course the drugs like opioids, anticholinergics, or all those things have to be taken into consideration. In almost 60% or 70% of these patients, with these conservative measures, will be able to take care of the situation in the next 2 or 3 days. And they say up to 6 days, it has been said that almost 80% will settle down, but you don't wait for the 6 days to have the next step of intervention, otherwise the chances of complications increase. And there have been large number of medicines which so-called prokinetic agents, which have been used, but all these medicines have not been of much use except for the neostigmine, which is more or less become, since the study in NEJM in 1999 by Kimi et al., has become the standard drug of choice for the use in these patients. There have been large number of studies done on the use of neostigmine, and 3 of these are randomized controlled trials, and this was the first one which came, and all 3 have shown that neostigmine is useful. And I'll just mention the landmark study which actually started the whole process, which was a prospective double-blind placebo-controlled trial with 21 patients, and all had a cecal diameter of 10 centimeter and had no response to at least 24 hours of conservative treatment. 10 of the patients on neostigmine had a prompt, that is between 3 to 30 minutes, colonic decompression, as compared with none of the 10 patients who received placebo. And treatment was considered to have failed in 3 patients who received neostigmine and 8 patients who received placebo. The dosage is, though standard is 2 milligram, but to cut down the side effects, some people advise that you may start with 1 milligram and later on may give another 1 milligram. It is an infusion over 3 to 5 minutes. People have used bolus, but then for the same reason, to cut down the side effects, infusion may be better. But one should have atropine available at the bedside. Patient is kept supine on a bedpan. I mean, said that experience is you start hearing the bedpan sounds immediately by the time you end up finishing the injection. And it needs a continuous EKG monitoring, so it has to be in the ICU setting or in the HDU setting, and is not to be used in the ward. And most of these patients actually will be in this setting. And there's a continuous clinical assessment for the next half an hour or so. There are significant side effects, which are not much like GI symptoms, but then yes, cardiovascular like bradycardia, hypertension, and bronchospasm are the key things, and the same sort of a setting of the patient will be the contraindication for the use of neostigmine, like a recent myocardial infarction or an asthmatic patient, active asthmatic patient, one should have, and serum creatinine more than 3 because its clearance goes down. As I said, that cecal perforation can occur in 3%, but that is only if it's not, it's late. But the key parameter which predicts that it may happen is if the cecal diameter is more than 12 centimeter. And now if the neostigmine fails, one can have a second attempt. If the second repeat attempt fails, then is the indication of a colonic decompression. It's not a pleasant duty. No gastroenterologist is very enthusiastic about it. The reason it's a dirty job, it's a messy job to do because you don't have to do preparation. It's a hugely dilated colon and it's a very time-consuming process. And then to do a colonoscopy in a dirty colon in an ICU is itself has its own hazards. But then if it has to be done, so we do it after the neostigmine fails. There's no preparation to be given. The endoscopist has to be cautious to use the minimal insufflation. One has to try to reach the cecum. It's not easy every time to reach in an unprepared colon, but then you start coming back and try decompress the colon. But quite often this will come back, and that's the reason some people have been using the decompression tubes in a setting like that. Ready-made sets are available. We have not been very enthusiastic about it, and actually most often we have not felt the need to use it, but then this option is always open. So colonoscopy decompression is with or without successful initially in 70 to 90% of patients with a recurrence rate of 10 to 30%, but the majority of patients will respond to a second colonoscopic decompression. Surgery is extremely rarely used, and is reserved for the patients with all these efforts fail, or there is a complication like a perforation. Or the other thing is, if the patient is sick, there is another option of doing a percutaneous cecostomy. These are done with a colonoscopy. We haven't done it, but this is almost the same procedure as we do a feeding endoscopic gastrostomy. But the chances of leakage of the fecal material in the peritoneum will be higher as compared to the gastrostomy. So one has to be very cautious in doing that. But if somebody has to open, it's a nightmare because that's what we get, and it becomes difficult to close the abdomen. So I'll sum up this presentation by this algorithm, that when a patient has acute massive colonic dilatation, the key thing is to rule out perf and obstruction, mechanical obstruction. Once you've done that, then the conservative management, as I mentioned, trial for 24 to 48 hours, and identify and treat reversible causes. If it does not settle then, and the cecum diameter is more than 12 centimeters, and you don't wait for 48 hours, and then you go for a IV neostigmine. If no improvement, try a repeat dose. If that fails, then you go with colonoscopy, and there is no improvement, then maybe a percutaneous cecostomy or surgery, and that's should be able to take care of most of the patients. Thank you.